Good day. Welcome to the basics of stroke volume and cardiac output, a very basic overture to hemodynamics for the Rise Up Critical Care course. And so let's get right to it so that we have a good understanding of stroke volume and cardiac output. All right, so you might recall in our other hemodynamics components, we talked about the difference between pressures, pressure in the artery versus pressure in the vein. Pressure in the artery is a reflection of ventricular ejection and vascular tone. So systemic arterial systolic pressure represents LV ejection, and systemic arterial diastolic pressure represents vascular tone. The same is true for the pulmonary artery. The pulmonary artery systolic pressure reflects right ventricular ejection, and pulmonary artery diastolic pressure represents pulmonary arterial tone. The venous pressure, the pressure column generated as the ventricle is ultimately filling with volume, is reflected into the atria and reflected into the veins that fill the atria. So, for the filling pressure of the right ventricle, the venous pressure is measured in the central veins or in the right atria. And the filling pressure of the left ventricle is measured in the left atria, the pulmonary veins, the pulmonary venules, or in the diastolic pressure or the wedge pressure of the pulmonary artery. We care a lot about our blood flow dynamics, and blood flow dynamics are actually measured in the systemic artery as stroke volume and in the pulmonary artery as cardiac output. Now, you would say, well, wait a minute, cardiac output is stroke volume times heart rate, but I'm talking about measurements. We measure stroke volume in the systemic artery, and we measure temperature change over time, which is an indirect calculation for cardiac output in the pulmonary artery. Can I calculate cardiac output in the systemic artery? Yes, by stroke volume times heart rate. Can I calculate stroke volume in the pulmonary artery? Yes, well, cardiac output divided by heart rate. Stroke volume times heart rate yields cardiac output. Cardiac output divided by heart rate yields stroke volume. And then, last but certainly not least, is tissue oxygenation. The left heart is ejecting volume that is optimized with oxygen, and we measure that as SpO2. SpO2 means measured from your pulse ox, non-invasively. SaO2 is measured from the arterial blood gas. The right heart mobilizes relatively deoxygenated blood up into the pulmonary artery, and if I drew a blood gas from the pulmonary artery, I would look at the saturation of hemoglobin therein. That would be called the SvO2. If I draw a blood gas from the central vein, actually recognizing that deoxygenated blood, that would be called ScVO2. SvO2 is mixed venous, and ScVO2 is central venous. And they are both deoxygenated hemoglobins that represent what the cells used as blood went from arterial side to venous side through the capillaries. It's a beautiful day. It's a beautiful day in the hemodynamic neighborhood, that's for sure. Now we want to remind ourselves about those other basic concepts when we talk about the cardiac cycle and we talk about the atria and ventricles, both filling, having those filling phases and contraction phases. We're most importantly interested in the optimization of ventricular filling. Now, as the right ventricle fills with blood from the systemic venous circulation, the column of pressure is a reflection of the atria, the valve, and the ventricle, right? From right atria through tricuspid valve to right ventricle. That optimized filling pressure is known as CVP. When we talk about the left ventricle filling pressure is optimized and evaluated by looking at pulmonary artery diastolic pressure or pulmonary capillary wedge pressure, which reflect the column of blood from pulmonary vein into left atria through the mitral valve into the left ventricle. So that's the filling pressure. The ejection pressure, remember, is a reflection of the work of the left ventricle to eject volume into the systemic artery, We call that ejection fraction, which is stroke volume divided by end diastolic volume. We look at the left ventricular stroke volume, which we can measure in the arterial bed. And we look at our systemic systolic pressure, which reflects the bolus of blood from left ventricle in the systemic artery. If I'm looking at the right heart actually boluses blood into the pulmonary artery. I can't really measure stroke volume in the pulmonary artery, but what I look at is temperature change over time. That is known as thermal dilution cardiac output. And that temperature change over time is over a minute's period of time, looking at the change of temperature in the blood after a signal has been introduced, either a cool signal or a warm signal, that changes the blood temperature. And how long it takes that blood temperature to get back to normal is what gets calculated as cardiac output. The other thing that we can look at is pulmonary artery systolic pressure, which reflects the response of the artery to right ventricular ejection. It's a beautiful day and a beautiful thing that we can measure. So we always like to correlate this to remember that the veins have a responsibility to fill the atria, and the atria has a responsibility to fill the ventricle. Right-sided filling pressures, known as CVP, are typically 4 to 8 millimeters of mercury. They can drop down a significant amount. They also can be forced up a significant amount with positive pressure breathing. The filling of the left ventricle, we typically use pulmonary arterial occlusion pressure, also known as wedge pressure, capillary wedge pressure, and very importantly, to correlate that as well as the PA diastolic pressure. So PA diastolic pressure, wedge pressure, ultimately are about the column of pressure filling the left ventricle. The right and left ventricle also have a responsibility to eject into arteries. So we look at RV ejection into the pulmonary artery and reflecting that in the PA systolic. And we look at the LV ejecting into the systemic artery, and we look at that as systemic arterial systolic, both of which are a reflection of the ventricles that eject into those arteries. And then, last but not least, we look at arteriolar tone. Now, that diastolic pressure in the artery is different than the diastolic pressure in the ventricle. Diastolic pressure in the ventricle is about the pressure column to fill the ventricle. Diastolic arterial pressure is about the constant pressure in the artery that is driving perfusion. So we look at arterial diastolic pressure as being a primary reflectant of the arterial tone, which is what generates your resistance and which is what promotes the blood flow dynamic through your capillaries, delivering oxygen and nutrients. It's really an incredible physiologic state. So we look at our pulmonary vascular tone, that's the PA diastolic, normally 8 to 15 millimeters of mercury, and the systemic arterial tone, which is measured as systemic diastole, as 60 to 80 millimeters of mercury. And that diastolic tone is reflected and affected by ventricular ejection, but more significantly affected by vascular tone. So that makes you know that if your systolic pressure is low, I might need to encourage a better contraction from the ventricle filling that artery. And if your diastolic pressure is low, I might need to consider your ventricular ejection, and I might need to consider vasopressor therapy. It makes perfect sense when we look at it in this way to separate it out and to understand it more in depth. Okay, so when we talk about the anatomy of filling an ejection, always really important to remind ourselves you must fill your ventricle in order to have an ejection. It's a very important concept. Fill the ventricle. Optimize the filling, and through the property of myocardial contraction, your myocardium will overcome the resistance at the valve and into the arteries in order to bolus blood out into the artery. So this is really, really important. But most significant to what I want to talk about in this content is actually the measurement of ventricular efficiency, which is hard to do because we don't actually have a true measurement of ventricular efficiency. What we like to talk about is ejection fraction and stroke volume, because that's a reflection of ventricular efficiency. So, Remember we talked about what cardiac output is. Cardiac output is stroke volume times heart rate. And let's be sure we appreciate stroke volume is the best indicator that we have at the bedside to actually evaluate ventricular efficiency. Cardiac output is heart rate times stroke volume. So you know that if the heart rate goes up, your cardiac output will be greater even if the ventricle is inefficient. And in fact, a lot of times the heart rate goes up to compensate for a failure of ventricular efficiency. That's a really important concept for us to appreciate. That's why you might remember I have said over and over and over and over again, tachycardia is considered compensatory for a low stroke volume until proven otherwise. Tachycardia is considered compensatory for tissue hypoxia until proven otherwise. So what does that mean? No good nurse lets the investigation of tachycardia go uncovered. Always consider that that is an inefficient way to drive up your cardiac output. The most efficient way for you to drive up cardiac output is to increase the what? You're right, stroke volume. Increase the stroke volume. You try to do that with volume, and you try to do that with an inotrope. That's a really important concept. We want to make your ventricle efficient. The most important function of stroke volume and stroke volume times heart rate, which is cardiac output, is to maintain blood flow and deliver oxygen to the tissue. It is the main one. The problem, of course, is, and let's see if I can make my hands work well, which I'm not sure I can, is that as my heart rate and stroke volume go up, my cardiac output will go up. But at some point, this hand representing heart rate, or this hand representing stroke volume, as my heart rate continues to go up, I have no time for filling of the ventricles, so my stroke volume goes down. At this point, I have actually delinked my heart rate and my stroke volume. Now, we don't know at what level that is. It's dependent on the patient's cardiac status, their coronary arteries, the ventricular compliance, and their age. The older you are, the lower the heart rate, stroke volume connection is. And as my heart rate continues to go up, my stroke volume will go down quite quickly. Now, we actually have a name for this. That's called the bow ditch effect. The bow ditch effect is heart rate and stroke volume go up together until they don't anymore. And the point where they don't anymore, you need to say, I've got a tachycardia that is an attempt to compensate but is actually causing decompensation. And such an incredibly important tool for us when we're evaluating critical patients. That's why no tachycardia should be left undiscussed. Cardiac output normally in liters per minute is 4 to 8 liters per minute. Cardiac output divided by body surface area gives us a more localized and predictable quantity of blood flow per body surface area. That's known as cardiac index. Normal cardiac index is 2.5 to 4. But I would tell you pretty much all of my hemodynamic mentors and heroes would say there is no normal cardiac output. The cardiac output that is normal is the one that answers your cellular call for oxygen, which means cardiac output is only meaningful in reflection to whether or not you have tissue acidosis, metabolic acidosis. So a very important point to remember when we look at blood gases and then we look at correlating all this together, always be concerned about the metabolic state of the tissues. Okay, so major components that affect heart rate and stroke volume. Well, certainly we know the number one component is oxygen demand at the tissue level. The recurrent stimulation of the sympathetic nervous system, which increases your heart rate and which increases your stroke volume to a point, and the amount of volume the patient actually has. Now, it's really important to remember, and we'll talk a lot more about this, especially when we talk about renal function, is that volume actually exists in 3 compartments, or 3 compartments that I care about. extravascular or interstitial, intraarterial as a subset of intravascular, and intravenous as a subset of intravascular. I frequently see patients with very high intravenous volume and very high extravascular volume who aren't making one drop of urine and who cannot control their blood pressure because they don't have arterial volume. So are they hypervolemic? Yes, in the interstitium and intravenously. But they are intra-arterially hypovolemic. And that's why we look at hemodynamics, and that's why we require a very well-educated critical thinking nurse at the bedside of these critical patients. Because we have to not just respond to numbers, but to understand the theory and to understand physiology and pathophysiology. Now let's remind ourselves that if our tissues are hungry for oxygen, one of the first things that will happen is there will be a venoconstriction. That means that your venous pressure goes up. The venoconstriction means that we're actually squeezing more blood back to the right heart in hopes that it will reach the left heart. And arterial vasoconstriction, reducing blood flow to low oxygen requiring organs like your periphery. That's why hands and feet are often cold. Your peripheral nerves, your skeletal muscles, shifting that blood flow to high oxygen requiring organs. And by the way, although components of the kidney actually use a lot of oxygen, the main function of the kidney, which is the filtering that occurs at the glomerulus, doesn't require much oxygen. So we actually vasoconstrict and reduce the blood flow dynamic to the kidney, which means that urine output goes down. Now that urine output goes down because the kidney is absorbing more volume to send it to the veins, to send it to the right heart, in hopes that it will reach the left heart, which doesn't necessarily occur. And of course, last but not least, increasing contractile response. So in a critical patient, you expect venoconstriction, reducing urine output, which is, by the way, in the beginning, renal success, not renal failure, vasoconstriction, and an enhanced contractile response of the myocardium, all in order to increase your stroke volume and hopefully promote a better cardiac output. So it is always important to consider that tachycardia is the most visible objective tool that you can measure that says there is an attempt to compensate, to improve the cardiac output and/or the stroke volume. Just remember that at certain rates, you actually become disengaged between heart rate and stroke volume. They're always engaged until they're not, right? So don't forget that. That's a really important uncoupling technique. So many factors affect heart rate. Lots of things affect heart rate. Chemical regulation, that's about our catecholamines, about acidosis and alkalosis. Depressed cardiac function, that occurs with hypoxia, and again, acidosis and alkalosis. Why do acidosis and alkalosis affect your heart rate and your contractile property? Because it's always important to remember that the metabolic acid hydrogen exchanges places for the intracellular depolarizing ion, potassium. So because potassium gets displaced, that's going to affect the heart rate. It's going to affect the cardiac function. The most significant hormone that affects the myocardium is the thyroid hormone. Thyroid hormone actually has hundreds of properties, but not the least of which are the synergistic application, uptake of catecholamines to increase our heart rate. And of course, electrolytes, especially as it relates to the appearance of metabolic acidosis and alkalosis. And the most important electrolyte is potassium, and that's for depolarization, and you cannot have contraction without depolarization. And then calcium, which is responsible for some depolarization, but which is infinitely more important to maintain myocardial contraction. So many factors affect our heart rate. They also affect contractility of the myocardium, and we always have to be thinking about that when we see that a patient has persistent tachycardia but a low stroke volume. We always want to consider the properties of events that might affect that. Acidosis, alkalosis, hormone, potassium, and calcium. Now that's not everything there is to know, but for our purposes, a very good start on what we should be evaluating when we see that our patient has an increased heart rate. So we always want to remind ourselves about our nervous system controlling the heart rate, right? So we think about the sympathetic nervous system, which most of the time is actually understood as the fight or flight system, that it actually increases heart rate, increases contractility when we have stimulus to the sympathetic nervous system and, by the way, responsive neurotransmitters. Okay, now what are neurotransmitters? They're catecholamines that have moved into place. The two major catecholamines, epinephrine and norepinephrine. So those are in circulation all the time and they are regulated by the adrenal glands. And we've got norepinephrine and epinephrine as circulating catecholamines. Once they get into position, and that is to carry the impulse to the receptor site, norepinephrine and epinephrine become neurotransmitters. And they are transferring the nervous system stimulation to the actual site. So we have the beta-1 site that's found in the sinus node in the AV junction, primarily beta-1, secondarily beta-2. And down in the myocardium, primarily beta-2, secondarily beta-1. So it's all beta, not alpha. Alpha's out in the arteries. Beta, responsive to epinephrine and norepinephrine. Alpha actually also responds to circulating catecholamines, epinephrine and norepinephrine, but those receptor sites are different. They are found embedded in the arterial wall, and with stimulation of the alpha receptors, we'll see vasoconstriction. So we think about this as it controls the heart rate, also as it controls contractility, and as it affects our arteries. The other half of the nervous system, of course, is the parasympathetic nervous system, which is a relaxation response, decreasing heart rate, decreasing contractility, and decreasing conduction through the AV junction. Parasympathetic stimulation is transported by the neurotransmitter acetylcholine. And acetylcholine is actually recycled right at the site, recycled when it's been discharged and used again right at the neurotransmitter site. So that's really important. Nervous system controls heart rate, nervous system controls contractility, and nervous system controls arteriolar tone. Okay, so one of the most important things that we think about when we talk about heart rate and our cardiac cycle, always important to remember that when the heart rate increases, all phases of the cardiac cycle decrease. They shorten. But what is particularly and profoundly affected is filling time. When diastolic time, diastolic filling time decreases, we actually see a decrease in compliance. So the ventricle gets stiffer, the filling pressure goes up, but less volume is in the ventricle. And this is really extraordinary for us to remember. So we might actually see that the patient has a normal cardiac output because as the heart rate goes up, the cardiac output will stay relatively constant. But when we look at stroke volume, we see that the stroke volume is low. So a high heart rate with a low stroke volume, this is a big problem. And we have a responsibility to figure out why that heart rate is high. That heart rate's high because the tissues are hypermetabolic and they're producing metabolic acid. You never want to decrease the heart rate with a beta blocker, but you might want to optimize ventricular filling. As you optimize ventricular filling by giving volume, or actually even promoting ventricular relaxation, the heart rate will naturally come down by itself. So I know I've shown you this before, but I'm going to show you again. Just to remind ourselves, we have ejection, filling, systole, diastole, eject, fill, 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 eject, eject. I can't say it fast enough. And you see there's no time for filling. So diastolic filling time is down, filling volume is down, compliance is less, and filling pressure goes up. Now I've exacerbated volume in my central veins and into my interstitium, into my pulmonary veins, into my pulmonary interstitium, and this is related to how fast the heart is beating. So I want to again remind you, no good critical care nurse lets tachycardia go undiscussed or undiscovered. Tachycardia is deleterious for patients. Even while it's compensatory, it is also deleterious. And by the way, we don't let compensatory mechanisms persist. They are compensatory for a problem. Treat the problem. That makes sense. It's really important for us to remember, too, when we're talking about our hemodynamics and how we evaluate our patients. Okay, so I happen to be in love with stroke volume. When my daughter was 3, she'd say, "Are you going to marry it? Do you want to marry it?" Yes, I'd love to marry stroke volume because it's always very fluid and it's flowy, just like how I'd like to dress. Fluid and flowy. Stroke volume. Stroke volume is the amount of blood ejected with each systolic contraction. It's a really important aspect of evaluating our patient's efficiency. Stroke volume is end diastolic volume, the amount of volume filling the ventricle, and what's left at the end of systole. EDV, end diastolic volume, minus end systolic volume. That reflects your stroke volume. Your stroke volume divided by your end diastolic volume is what gives you ejection fraction. But at the bedside, where I'm not doing continuous echocardiogram, I can evaluate continuous stroke volume. And when I add a vasopressor and the stroke volume goes down, I might have made your blood pressure better, but I made your blood flow worse. So I always want to think about stroke volume. I always want to look at what stroke volume is. And I always want to consider what happened to stroke volume in relationship to my therapies. Stroke volume should go up when I give volume. Stroke volume should go up when I give an inotrope. Stroke volume might go down when I give a vasopressor. So that means when I'm at the bedside with complete and utter power to turn up a vasopressor because my patient's blood pressure has dropped, I am not helping the patient if I'm going up on the vasopressor to try to get a better blood pressure, but the patient's stroke volume is going down. Because now what I've changed is blood pressure for blood flow. And I'm really all about blood flow. Now, stroke volume index is stroke volume divided by BSA. So we know that normal stroke volume is 60 to 100 mLs per beat, but you can go up to 200. When you need more stroke volume, you can maximize stroke volume up to about 200. You do that when you ride a bike or when you're running or when you're doing hard exercises, your stroke volume goes up if you have a normal healthy heart and adequate volume. Normal stroke volume index on our equipment will be 25 to 35, but there are different requirements for stroke volume index. So I just urge you to look at what your equipment is displaying to you as a normal stroke volume. Okay, so one of the beautiful things about stroke volume is that stroke volume reflects ventricular efficiency and ejection fraction. It's a poor man's way continuously to evaluate ejection fraction and ventricular efficiency. So it's really awesome to be able to look at your stroke volume and correlate that to your ejection fraction, to your ventricular efficiency, and to remind yourself that with a critical patient, what you want to do is improve ventricular efficiency. So again, if I give you volume, stroke volume should go up. If I give you inotrope, stroke volume should go up. If I give you vasopressors, stroke volume should not go down. If stroke volume goes down, I have now made my ventricle inefficient. And in the pursuit of what I love, which is blood pressure, I have profoundly limited what is essential for life, stroke volume. So I'm always going to look at that relationship, reminding myself that the right ventricle has a lower ejection fraction than the left ventricle does, and always being aware that the right ventricle is afterload dependent, the left ventricle is afterload sensitive but not dependent, and always consider that what I really want to do is optimize ventricular ejection. Okay, so what are the 3 major factors that affect our stroke volume? I've said how important this is. Well, first of all, your volume. Well, we can't measure your volume. So what we measure is the column of pressure related to ventricular filling. That's known as preload pressure. Preload pressure is determined by the amount of volume filling the ventricle and the compliance or the stretch, the distendability of the ventricle at the end of diastole. So we've already talked a lot about this. Preload pressure is not volume, but it's the only thing we've got. Preload pressure for the right ventricle is measured as central venous pressure or right atrial pressure. For the left ventricle, for us, is measured as pulmonary artery diastolic pressure or wedge pressure. And if you could put a catheter in the left atria, it would be left atrial pressure. Contractility, which is the intrinsic property of the myocardium to contract, taking the filling volume and translating that into a ventricular ejection. Contractility is that intrinsic property of the myocardium to contract, to move the blood that filled it against the resistance for ejection. That is the contractile property. We're going to use stroke volume and we're going to use cardiac output to tell us about left ventricular contractility and right ventricular contractility. Now, these are very, very profoundly indirect surrogates. They are not great surrogates for afterload or contractility, but they're the only thing that in general we have. Afterload is the amount of tension that the ventricle must develop in order to overcome the resistance after ejection. And what we typically do at the bedside is a calculation of the mean pressure leaving the ventricle, that would be the mean arterial pressure or the mean PA pressure, minus the filling pressure at the end of the ventricle, so that would be for the left ventricle, mean arterial minus CVP, and for the right ventricle, mean PA minus wedge. That's the whole circuit that the ventricle has to bolus against. That's then divided by cardiac output, and it's converted into a measurement of resistance called dynes. And we'll see the formula a little bit later, but I definitely want you to understand that that's a calculated formula. In fact, all of this is indirect. None of it is direct. The only thing that's direct is your brain connected to the understanding. That's the only direct event there is. None of these measures are direct measures. None of them give you the whole picture. It's all of them together in the wise mind of a provider that actually allows us to facilitate accurately and appropriately what we need to do. Okay, so the volume load to your ventricular chamber, either it's compliant or it's non-compliant, that's going to yield your filling pressure. So remember, right ventricular filling pressure measured in the systemic veins looks at the column of blood as it transitions into the right ventricle. And left ventricular filling pressure measured in the pulmonary artery measures the column of blood as it transitions to the left ventricle. Now, there's a lot of barriers between the vein and the ventricle. Most importantly, the atria and the valve. That's a really big deal. But what we want to remind ourselves is if we have a central line, so I'm sorry, I don't want to offend anybody. I don't care if my physician orders central venous pressure monitoring. I'm always going to connect a transducer to the distal lumen of my central line so that I can always monitor central venous pressure. Now, I'm not monitoring central venous pressure as a volume indicator, and that's one of the reasons that CVP monitoring has lost some of its allure, because folks wanted it to mean volume. It was never volume. It's always about the compliance of the right heart on being filled with volume from the central vein. So we as staff and as nurses, we choose to hook patients up to monitoring. We don't need an order for that, but what we do need is the ability to actually explain the information so that it's meaningful. So remember, venous pressure, right ventricular filling or left ventricular filling, right ventricular filling pressure measured in the central vein indicates volume over change in compliance. So if my heart is beating 150 times a minute, I'm going to expect my CVP to be high. But that doesn't mean I have high volume. I might have neck vein distension, I might have interstitial edema, but if I'm hypotensive and I'm in acute kidney injury, I've got volume, it's just in the wrong place. And I need to be able to explain that when I'm communicating with my physicians. Left ventricular filling pressure is going to be measured by, of course, your PA catheter with the wedge pressure or PAD, but it's also going to be subjectively evaluated by the presence of interstitial volume in the pulmonary bed and the failure to oxygenate patients. And again, we really have to understand this and measure it and be able to explain it appropriately. Okay. So always remind ourselves that filling gradient is reflected with pressures. Central veins fill the right atrium fills the right ventricle. Pulmonary veins fill the left atria fill the left ventricle. So always remind ourselves that venous pressure is ultimately about the filling of the ventricle, and that venous pressures indirectly reflect ventricular filling pressure, which is about volume over change in compliance. And the biggest change that we see in compliance in front of our eyes on every patient is tachycardia and positive pressure ventilation. Both of those change profoundly on every patient. Now, some patients have an MI, they have a stiff ventricle. Other patients have valvular failure, so they have a stiff valve. So many other things affect our filling pressure, but on a standard daily basis, the most common are the heart rate and positive pressure breathing. Okay. Now remember, ventricular ejection is about the power driving the oxygenated or deoxygenated blood flow. So ventricular ejection is a measurement of both systolic pressure and diastolic pressure. And generally, we're measuring that in the arteries, not in the ventricles. So again, we're looking at arterial pressure with three components: peak systole, and diastole, and dicrotic notch, which is the transition between systole and diastole. Right ventricular ejection is measured in the pulmonary arteries. So if you don't have a PA catheter, you're not going to measure that. Left ventricular ejection, however, is measured in the systemic artery. So every patient that has an A-line, we should be able to measure LV ejection. And if we're only measuring that by changes in systolic blood pressure, so be it. But remember, we have a transducer called the flow track that we can attach to the A-line, and that flow track gets connected to an EV1000, and the EV1000 takes the area under the curve of the arterial pressure and displays it as stroke volume. Now, both of our ventricles eject into arteries, and the role of that arterial ejection is to maintain capillary perfusion. Capillary perfusion for the right heart, meaning gas exchange at the alveolus, and capillary perfusion for the left heart means gas exchange at the cellular level. These are incredibly important concepts. Whether or not you stick catheters in your patient, these are important concepts for us to appreciate and understand. So now we go back to our cartoon and we remind ourselves that the right ventricle ejects into the pulmonary artery, pushing that blood flow forward, so there's gas exchange with the alveolus, transitioning it from relatively deoxygenated and CO2 rich to relatively reoxygenated and CO2 poor. That blood then fills the left atria, the left ventricle, and is bolused into the systemic artery by your left ventricle. Your left ventricle boluses that blood into the systemic artery in order to drive perfusion past the cell to promote the use of oxygen at the cell and the uptake of carbon dioxide as a waste product into the blood. This is incredible, and this simple cartoon explains it all. Excuse me. And then we remember right to left sharing of circulation, deoxygenated blood to reoxygenated blood by right ventricular function, right ventricular ejection, right ventricular stroke volume, and pulmonary arterial systolic pressure reflecting that. Excuse me. And as that blood flows through the pulmonary artery, we now see the pulmonary artery diastolic tone, which actually is promoting capillary perfusion, and that's where gas exchange takes place. And then that blood flows back through the pulmonary veins to the left atria to the left ventricle. It's an incredible thing. Those pulmonary hemodynamics determined by the right heart actually are best evaluated non-invasively by the presence or absence of SaO2 and PaO2, which is all about right-sided blood flow through the alveolus promoting gas exchange. So remember, the right heart must drive pressure to push that blood flow past the capillaries, and to ultimately fill the left ventricle. That's your pulmonary hemodynamics for your right heart. The shared circulations from the left heart, so left ventricle fills and then ejects, measured by left ventricular stroke volume, systolic blood pressure, and as that blood flows through the arteries, driven by systolic pressure and resisted by the diastolic blood pressure, we actually have that goal to perfuse our capillaries. And what actually happens is we deliver oxygen into the cell and we remove CO2, and that blood now flows back to the right atrium and therefore the right ventricle. These are always shared circulations. So our systemic hemodynamics, which are left heart driven, are about the delivery of blood to the capillaries, to the systemic capillary perfusion, at which point we are going to use a couple of very significant indicators that we'll review in basic blood gas analysis. Those indicators are indicators of the profundity of tissue metabolism: lactic acid, keto acid, base deficit, and anion gap. And post-cellular blood flow, we will measure the use of oxygen by SVO2 and SCVO2. And as that blood flows back to the right heart, we're going to look at the resistance to right heart filling as central venous pressure or right atrial pressure. Oh my God, my head is exploding. I love hemodynamics so much, and I think the understanding of them actually changes our clinical practice to be more thoughtful rather than just reactive. So let's just remember, the ultimate reason we monitor cardiac output and stroke volume is because we are trying to answer a cellular call for oxygen. The major function of the cardiovascular system is to supply sufficient amounts of oxygen to maintain aerobic metabolism at the cellular level. Always responsive to metabolic demands, always responsive to metabolic acidosis, unless there is limitation of the cardiac response. It's the primary, single most important contributor to oxygen delivery, and it's the one that the individual can manifest the best by increasing their heart rate, by increasing their venoconstriction, their arterial constriction, and their contractility. That's how I respond when my tissues require more oxygen. But if I've lost my vascular tone, I can't do that anymore. If I've lost my vascular tone, I've lost both arterial dilation and venous constriction. And if I've lost contractile property, I can't do that anymore. Now I'm relying on you to understand what that problem is, and you to treat the problem, not just the symptom, which is hypotension, but the actual problem. To remind myself that the primary role of cardiac function, electrical and mechanical, is to deliver stroke volume to answer the tissue demand for oxygen. So last, but certainly not least, we always want to remind ourselves about the oxygenation gradient. So as we look at this simple cartoon one more time, what we're going to remember is the left ventricle fills with optimally oxygenated blood and ejects it out into the system. We use SaO2 or SpO2 to reflect the actual amount of oxygen that's available, not usable, available in the systemic arterial circulation. That's a reflection of right heart power and alveolar gas exchange. But the left heart moves that blood flow forward. That blood flow forward movement goes past the tissue capillaries, and the cells use the oxygen they need. So the blood that returns to the right atria is relatively deoxygenated. If I measure it in the central vein by drawing the blood gas from my CVP and sending it off to the blood gas lab, what that's going to reflect is how much oxygen my cells used. If I draw it from the PA catheter and send it off to the blood gas lab, or do that continuously, I actually am going to have a reflection of the mixing of all the venous blood flow as it comes back into the right atria and therefore into the right ventricle. So mixed gas means that I've mixed all my venous flow. Central means I'm only reflecting it in the central veins, and that typically leaves off about half of the oxygen utilizing organs. So it's very important to understand the difference between SCVO2, saturation of hemoglobin in the central veins, versus SVO2, saturation of hemoglobin in the pulmonary artery. The difference is central vein only reflects actually upper extremities and brain, whereas the mixed vein, SVO2, reflects all of the venous blood flow that mixes together in the right atrium, right ventricle. So very, very important for us to appreciate and understand that. Normal SCVO2, normal, is 65 to 85% saturated hemoglobin, and normal mixed vein is 60 to 80% saturated hemoglobin, which means if I went out at 100% and I come back at 80, I use 20% of my oxygen. Okay. So we think about those cardiac functions. We remind ourselves that the role of the left heart is to fill from the pulmonary veins, to contract and eject blood flow into the aorta, and to deliver oxygen to the tissues. In addition to that, of course, is removal of tissue acids and carbon dioxide. That the role of the right heart is to fill from the systemic veins, to eject into the pulmonary artery, to deliver blood to the alveolus in order to uptake oxygen and download carbon dioxide. It's an incredible thing. And you can't do one without the other. You must maximize efficiency and function of both right ventricle and left ventricle. And remind yourself that this happens at the capillary level. Capillaries at the alveolus uptake oxygen, download CO2. Capillaries at the cell download oxygen, delivering it to the cell, and take up carbon dioxide, which is the waste product, as well as metabolic acid hydrogen ion. Very important to remember that the left heart is the power of delivery of oxygen to the tissue. Right heart is the power of delivery of carbon dioxide to the alveolus. Thank you very much, and I look forward to talking with you again as we move forward. Thank you.